I had the privilege of going to this conference in early September. It was one of the best conferences that I've ever attended on prostate cancer. I learned a tremendous amount, and I hope that we can share that information with you guys here tonight. I know I learned a lot, and I'm sure you will learn something out of this. And I don't pretend to be an expert, but I give you enough information so you can follow up on it if you're interested and get more information. The conference was attended by 900 people, and it was for patients, as it says up there on the slide, helping patients understand their treatment options. Basically, there was, over the 3 days, there were 16 medical professionals gave a detailed presentation on prostate cancer treatment options. And they consisted of oncologists, urologists, pathologists, nuclear medicine specialists, support group leaders, and PCRI volunteers. All excellent speakers. Of course, many of the presentations were going on simultaneously, so you couldn't attend them all. I picked the ones I was interested in. Dan and Michelle picked the ones they were interested in, and that's why we're each doing a little talk on the presentations we attended. The roundtable discussions were extremely interesting. At the end of most of the presentations, you could ask questions. They were very, very helpful. They'd spend as much time as you wanted to stay there with them and put questions to them. They were very helpful and would try to guide you in answers to your questions. So I of course am very interested in reoccurring and metastatic prostate cancer. Most of you probably know I've been a warrior for quite a while, and my prostate cancer has come back 3 times since 2006. So happy to say at the present time I'm in the best health I have probably been since day one. So I'll just wrap on wood. Anyway, some of the things I learned at the conference was a bit startling to me. I never was told that here by any medical professional that treated me. For example, they have now a number of studies that have taken place in various countries across the world, and they've confirmed that after a radical prostatectomy, 20 to 50% reoccur within 10 years. That's not good news, but that's a fact. After an external beam radiation, 30 to 40% reoccur after 10 years. It makes wanting to find a cure for this disease even more pressing. Basically, up until recently, common tumor reoccurrence is assessed by progressive PSA. So if your PSA started to go up, you might get a CT scan. If you pushed, you might get an MRI. They would try and find where your prostate cancer had spread to, whether it was local or distant. And that's basically the way it was attacked today. Still pretty well the same here in Canada, but there are other options now, which are very interesting. So after a radical prostatectomy, if your PSA goes over 2.0 Ng, they're saying it confirms reoccurrence. So, and management and treatment strongly depends on whether the cancer is local or distant. Distant being that it could be anywhere, could have spread anywhere. Generally, like the bones is a common place that it spreads to, as we all know, but they're seeing more and more of it in other locations in the body, even in the brain. Only better imaging procedures can predict local or distant. Myself, for example, after a radical prostatectomy, my cancer reappeared, and I was given salvage radiation, 37 treatments in the prostate cancer bed, and they just hoped they had it. There was no imaging done to see that it was actually there, or was found, and there was no imaging that had the capability of proving that it was gone. So that's why better imaging procedures, which are available today, and I'll talk to them later, are very important in treating both local and distant prostate cancer. So imaging methods, some new treatment therapies can cause your PSA to rise initially. A rising PSA, if you're being treated by some various treatments, may not mean that your cancer is getting worse. That's a side effect of the therapy. So rising PSA when you're on some of the newer treatments doesn't mean that your cancer is increasing. Improved imaging scans are required to monitor both local and distant tumors during treatment. A lot of places in the U.S., they will do a scan every week while treatment is going on for 6 weeks. So they can actually see the tumors, regardless of the size, and monitor the effect of the treatment on the tumors. And if you think about it, that's pretty positive. PET imaging commonly performed is the fluoride FDG type, but the latest PC imaging tools are C11, and there's 2 types of C11, acrylate and chlorine. And they're considered to be you might say, the gold standard today. But C11 overall detection rate is approximately 90%. So if you have a rising PSA above 2.0, and they figure it's metastasized somewhere or reoccurred, with this type of a scan, they can find it 90% of the time. And you can see there, as your PSA rises, their detection percentage increases. Another imaging method is multi-parametric MRI, reduces the need for needle biopsies, whether they be 10, 12, 14, whatever you might have got. Anybody that's had one knows it's not too pleasant. And today, you don't have to have a needle biopsy if we have this imaging equipment available. Men with an elevated or rising PSA should have an MP MRI, as it is less invasive. An MPR MRI is a 1-hour examination and a Siemens scanner. And excellent for detecting prostate cancer. Now, you're going to probably ask me if we have one of these in Canada, and I don't believe we do. Radiation methods, again, there's improvement there. Image guided with gold marker in your prostate, that is one of the latest. Better accuracy given that your prostate constantly moves. Protein beam radiation has the greatest accuracy, and it was developed for brain and eye cancer tumors. And they have just started to do research of it on your prostate, but they haven't finished that research. And again, the problem here is the business model collapses for most hospitals. You're looking at a cost of $150 to $200 million per scanner. And in the US, they have them in the Mayo clinics in the East Coast, they have one. In the Central US, they have one, and in the West Coast, they have one. Therapeutic options, great treatment advances have been made in the last 5 years. I guess some of the leading specialists down there, for the first time, they're now saying they can find, with the tools that they have in their toolbox now, they can provide a durable cure for prostate cancer. And they've been saying that now for only in the last 2 or 3 years. They really believe that they now have all of the tools to cure a person, permanently cure them, if they're treated early and treated with a sequence of the various drugs that are available. Some of these treatments are as follows. Progon attacks your advanced prostate cancer by jump-starting your immune system. I have a couple of pamphlets on that I picked up, and I'm going to put it in our library if someone is interested in reading more about it. It's considered one of the major treatments today that they're using. Latest hormone drugs, of course, is some of them we already know about. Well, most of those on there we know about. But Extandia is one of the later ones, and they're having great success with that. And I tried to put the different names. That was one of the things I found confusing at this conference, being a medical conference. You know, different people call the same drug a different name. So it's kind of a bit confusing for a layman like me to try and understand that. But I did my best at putting both names there, if I could figure out what they were. With all of these drugs, side effects are generally mild. And many of these drugs are not given alone. They're given in sequence or in tandem and sometimes together. And that's the key to the success, they're saying. So the bottom line, therapeutic options, now with the right agents, optimal timing, and using them in the correct combination, a prostate cancer durable cure can be achieved. And one of the things I found really interesting, near the end of the conference, they took all of them on stage, all of the speakers, and they put up a theoretical case, prostate cancer case. And then they'd go down the line and asked each doctor how he would treat that patient. And that was extremely interesting. And they didn't all agree on the first pass, but usually before they finished, they had come to agreement on the tools they would use to treat that patient. So I found that very, very interesting. Diet and nutrition. I did attend a diet and nutrition discussion, and it was kind of interesting, but I don't know, I find that depending on what you read these days, something is good for you today and bad for you tomorrow, so you can take some of this with a grain of salt, I think. But bad for prostate cancer, corn oil. There's death against corn oil. Don't use corn oil. Don't use popcorn. And coconut oil, bad too. Flaxseed oil only should be used in paint, shouldn't be used in human consumption. So, kind of interesting. And beef, you know, we all know that red meat is not that good for us, but it surprised me a little bit that well done is worse. So, and I don't like rare, so I guess I'm in bad shape. I'll have to just eat fish. Good things for you. Most of you know about these, but there's a few things that I picked up. Olives and olive oil, excellent. Nuts, but especially nuts that grow on trees. Found that interesting. Peanuts, for example, regular peanuts, grow in the ground like potatoes, not good for you. Don't eat them. Bad. Any nut that grows on a tree, walnut, black walnuts, sir. We get some trees growing, we can eat them. Dark chocolate, of course, that's another one that's really good. And omega-3, although I've seen articles that that's not good for you anymore, so I don't know. Soy milk, it's supposed to be good. Pomegranate juice, blueberries. But the bottom line was, I guess one of the doctors there, Charles Snuffy Myers is his nickname. He said, look, he said, if you eat a healthy heart diet, your prostate will be fine. He said, patients come in to see me at my clinic, and they're 100 pounds overweight. They got high blood pressure. They got sugar diabetes. And he said their prostate reading is probably 3.8. And he said, I tell him, look, don't worry about your prostate. You got a lot more things to worry about than your prostate. So, you know, it's all relevant, I guess. But if you eat a heart-healthy diet, you shouldn't have a problem. Here's some reference numbers and websites that you could go to. I personally have called that number since I got back. I had a couple of questions, and I found them extremely helpful. They had to go and look up some information. They got back to me within about 20 minutes, and really, really helpful. And so if anybody has a question related to treatment or whatever, don't hesitate to call these guys. I met most of the people that work in the call center, and they're extremely knowledgeable. Most of them are volunteers, but they have a reference to doctors right away. So, and it's free, so if you want to use them, go ahead and use them. There was one interesting thing that I picked up at the conference. I found it really interesting. It was kind of a side talk at the end when they were all up on the stage there. And the comments that they made really struck me, because they said that we have great advances in treatment. Like we have the Da Vinci robot machine, okay? And we have laparoscopic surgery, and we have better methods of doing radical prostatectomies than we've ever had. But the cure rate has not improved one iota. They have enough data now, and these new techniques have been available and been used long enough that they have quite a bit of data, and there's no improvement in the cure rate as to whether you had an open radical prostatectomy or a laparoscopic one, or one done with the Da Vinci robot. I found that was rather interesting. We all would like to see them find a cure for this dreaded disease. That was kind of interesting to me. The other comment that was made is that many hospitals in the US and overseas are in competition with each other to get the best and latest, let's say, Da Vinci robot. I'll just use that as an example. And maybe that's not the best way to spend their dollars. Maybe they need to buy some better imaging equipment, for example. So I found some comments made like that which were really interesting. We don't hear that. So there was one other presentation I attended by a pathologist. His name was David Kresny, and he's been practicing for 35 years. He works in a hospital in Santa Monica, California. He was trained in Sweden. Very, very interesting individual. He said he claimed that one of the major advantages still today was a radical prostatectomy. Now, he's a pathologist, so take this with a grain of salt, I guess, but he claimed, with his experience now, if he looks at numerous prostates on the table, and he shocked me with some of his information, which he said that not always do I get the whole prostate. He said sometimes pieces are left behind. Now, they may be left behind for various reasons. The doctor's trying to save some of your sex organs, whatever. But he said, sometimes I don't get the whole prostate. And he said, when a patient never gets to a PSA reading of 0, he said, maybe they will never get 0 because there was some of the prostate cancer, good tissue left behind. Doesn't mean they have cancer. They may be cured with the radical prostatectomy, but they may always have a small reading, and that would be normal for them. So he brought some things to light that were quite interesting. He also predicted that he's often called in by other hospitals and so on to consult on a prostate cancer, and he claimed by looking at the prostate that's been removed from a patient that he could predict 99% of the time if that patient was going to reoccur, just by studying his prostate and the cancer in his prostate. I found that extremely interesting. And he said that you know, most of the pathologists that look at your prostate when it's removed from you, you know, okay, the cancer was here and there, and give you a reading and a report, but he says, it's not a detailed study. So I found that very interesting.